not sure what else to do about it at this point. I think that's recording. Yes.
All right. So we're talking about preload. The greater stretch prior to contraction will increase the strength of contraction. The Frank-Starling law of the heart keeps both ventricles pumping the same amount. So for instance, if the left side of the heart pumps more than the right side of the heart, then that amount of blood from the left side of the heart should be returned to the right side, and then the right side will have to pump that amount out. So that's the Frank-Starling law of the heart. If one pumps more than the other, that venous return will bring that blood back and keep both ventricles keeping the same amount. So that leads us to the next thing, the two major things that affect preload. One of those is going to be the venous return. Obviously, I said that if the left ventricle were to pump more than the right ventricle, the Frank-Starling law of the heart keeps those pumping roughly the same amount, because that blood that was pumped out from the left side into the aorta has to be returned back to the right side of the heart, so it should pump the same amount. So anything that is blocking venous return, how much blood is returned to the other side of the heart, will affect the preload. So if something is inhibiting return of blood to your heart, then therefore you're going to have less stretch on the heart. You're going to have less blood that returns to it. The other thing that affects it, second, is duration of ventricular diastole. As being blood going into the ventricle. Okay? All right. So it doesn't show everything perfectly, but it does show some. So let's say that this is the left ventricle, and when I put my mouth on it to blow air in it, this is going to be blood going into the left ventricle. Think about this as the venous return. So blood returning from the veins goes into the left atrium, which then goes down into your left ventricle. Okay? So the larger amount of venous return is going to return more blood to this ventricle. Okay? I want to say something really quick. Please do not pop these. I have a phobia of popping balloons, and I will hate you if you pop this balloon. Do not pop it. I know I had to volunteer once at like a little kids dance or some party or something, and I walk in and they just had blown up, laying all over the floor of the gymnasium where things echo. It was like my worst nightmare. I was constantly skittish the whole time I was in there because there were kids running around everywhere. The whole floor was covered with fluids. It was the worst day of my life. Anyway, so think about if there's a small venous return, or there's a small degree of stretch on this balloon. How forcefully does air come out of it? Pretty quickly. This video is going to sound funny. But if we have a whole lot of blood return to this, so a whole lot of air, I'm not going to blow it up much more than this because I don't want it to pop. Then you're going to have a more forceful contraction because this was stretched more, okay? You can also think about this with rubber bands. So I'll give you a rubber band too. Don't flip anybody with a rubber band. Yep. Balloons and rubber bands, I know. I'm being hesitant thinking about this. You can also think about the preload as a stretch of a rubber band. Now what we are not going to do is flip somebody, but let's say that you are going to flip the person's head behind you, right, or sitting in front of you, right, not behind you. Okay? If you were to pull this rubber band back, if you really wanted to have it the maximum input, how would you pull this back? You'd really pull it very far, right? The greater the degree of stretch, the more force it's going to have. That's kind of how the heart works. So the more it's stretched, the higher the preload, the more it's going to forcefully contract. So the greater the amount of venous return, what we just saw with the balloon, the more forcefully the heart has to contract to push that out. And the Frank-Starling law says that if a large amount of blood has come from the left ventricle, larger than the right, that venous return has to bring it back to the right side, so it keeps both ventricles pumping roughly the same. Now the next one is a little bit harder to see with balloons or rubber bands, but it should make sense. So the second major thing that preload is contingent on is the duration of ventricular diastole, okay? So you can think about it a little bit in the balloon. What happens if I just blow in this really quick? Not much in there, right? There's not much that comes out. But if I blow in it a long time, it stretches more, right? Because I have more time to blow this up. So think about this as the time we have to blow the balloon up. If you say, blow up this whole bag of balloons and I'm going to be back in 5 minutes, and I just give them to Corey, we'll say, he's going to have to go and then just throw one down and get the next one because he doesn't have enough time to blow these up really big. But if I say I'm going to give you 5 hours, then he has tons of time to blow these up where they're nice and big and tie them off. Okay? So the duration of ventricular diastole, which again is relaxation, will give your heart more filling time. So this is why it can be dangerous for a person that is not in very good shape to get a really, really high heart rate whenever they are not really ready for that when they work out. Okay, so if you still have those worksheets that I gave you, I had one more question left in it. Well, I had the matching stroke volume, but the very last question was a critical thinking question. So it says, unathletic Sylvia resolves to begin an exercise program. She tells you that she wants her heart to make her heart beat as fast as it can during exercise. Why may that not be a good idea? Okay. Your heart won't explode, but it doesn't damage the heart. But what happens is you have less preload. Whenever your heart rate rises above 160, your preload decreases to the amount cardiac output decreases to your tissues. So if you are working out, your heart rate is going to go up, right? Well, your ventricle has less time to fill. So guess what? It just pumps out the blood that's in there. What can happen eventually is that you cannot get enough blood directly to the brain, okay? This is why highly trained outputs, having a low heart rate, is a good thing. Because when a highly trained athlete undergoes physiological cardiomegaly, which I talked about before you left on Thursday, so enlargement of the heart muscle, which is a good thing in physiological cardiomegaly, due to working in it in aerobic exercise, they have a lower resting heart rate. Low resting heart rates mean that your duration of ventricular diastole is longer, therefore your filling time and your preload is longer. So the heart ventricles can fill more, they can stretch more, and your heart can more forcefully contract it out. So you're more efficient at getting blood to the body. So that's one of the goals of long-term aerobic exercise, is to have a lower heart rate so that way you don't lose that filling time and you can more efficiently get blood to your organs. Okay? All right, questions over preload. So just hopefully the balloon will be a good reminder there of how venous return and duration of diastole will affect it. Yes?
So when your heart rate gets above 160, the preload decreases to the amount of carbon.
No, this is cardiac output.
Oh.
Cardiac output, yeah.
I'm like.
CO cardiac output, sorry. So your cardiac output is going to decrease there. So basically it declines to less filling time, so your preload is lower. You get a larger stroke volume, you're prolonged, because the filling time is prolonged. Okay. Maybe I should say stroke volume decreases. That would be better. So let's say stroke volume decreases, and that'll also make more sense when you go back through and read it. All right. Contractility is the actual forcefulness of the individual muscle fibers. Obviously, you're going to have a decreased stroke volume if your cardiac muscle fibers are not contracting very forcefully. So here I have a nice picture of a heart lifting weights. Contractility. So the definition, pretty simple, the strength of contraction at any given preload. So we said that the heart will contract more forcefully to push out higher volumes of blood in a increased preload. But there are things that can also affect the contractility of the heart directly. I'm going to try not to use that green marker because I think it's kind of light to see in the back of the room. But we can divide up things that affect your contractility into two categories. We have positive inotropic agents and negative inotropic agents. Okay. Positive inotropic agents increase contractility of the heart muscle. And negative inotropic agents decrease contractility. So when you have a positive inotropic agent, your stroke volume increases when that agent is present, when you have a constant preload. Usually they are things that promote influx of calcium ions. So that goes back to what we talked about last week. Calcium can depolarize those fibers, and calcium can make the heart contract more forcefully. So the more calcium you bring in, the more forcefully a heart can contract. There's a drug called digitalis. This is an important drug to be aware of. That can increase that. So it can increase contractility if someone is on the drug digitalis. Other things, your sympathetic nervous system. So we're talking about epinephrine and norepinephrine here. They will increase contractility. Yes?
Does digitalis increase contractility and calcium?
Well, basically what we're talking about is if it promotes the influx of calcium, then it does increase contractility. So that's why it's in a positive inotropic agent. Right? So directly related there. So it just strengthens the force of the next contraction. Things that are negative inotropic agents, we'll say inhibition of sympathetic nervous system. Calcium channel blockers. Sometimes something like that might be prescribed for high blood pressure. So calcium channel blockers. Anything that increases potassium influx. So what did potassium do when we looked at the action potential graph of heart muscle cells? Repolarization. So if we increase that, we prolong that repolarization and relaxation. So we're looking at the opposite here. Calcium channel blockers, increasing potassium influx. Anoxia, this is just basically low levels of oxygen will decrease contractility, as well as acidosis. And I'm not going to go into all the details about that yet, because we will talk more about acidosis when we get to the respiratory system.
What is anoxia?
Low oxygen. Yes?
Okay, so if somebody had bradycardia, would they take digitalis?
Well, what we're thinking about here is kind of two different things. These are inotropic agents, and they either increase or decrease contractility. Now, bradycardia is a heart rate under 60 beats per minute in an adult, when we're thinking about it not in a highly conditioned adult. So let me go ahead and write this down so we can kind of introduce a new term here. This is the only thing I'm going to say about it. So I'd write the term down and know what it is, but your book doesn't go into it really, so I'm not going to go into different agents. But chronotropic agents, as opposed to inotropic agents, affect heart rate. So a positive chronotropic agent speeds heart rate, whereas a negative chronotropic agent lowers heart rate. Now, to answer your question directly there, your sympathetic nervous system, epinephrine and norepinephrine, can increase contractility, but that will also increase heart rate, so that the sympathetic nervous system can speed that up. Now, what we'll talk about next is nervous supply to the heart. We purposely didn't say parasympathetic stimulation as an inotropic agent because parasympathetic stimulation would slow heart rate, would be a negative chronotropic agent, but it wouldn't necessarily decrease contractility itself. So chronotropic agents affect heart rate, inotropic agents affect contractility specifically. Great. Now this is just something that if you're ever looking back through this in nursing school and want to go back through, this was a nice little pin that I saw on Pinterest. It's a good mnemonic for several of these drugs that are negative inotropic agents, and they are calcium channel blockers. Now having said that, you do not need to know the names of these negative inotropic agents, these calcium channel blockers up here, okay? So I'm not going to ask you about those in particular, because we don't usually get into high amounts of drug names in here, just some basic types of things. Just know that those are calcium channel blockers, and at some point that will be what we use. All right, questions over contractility. Okay, and finally looking at the afterload. We said preload was the degree of stretch on the heart, so it could pump out more blood into the pulmonary trunk or aorta. Afterload is the pressure that's in this pulmonary trunk or the aorta that must be overcome for the blood to push out into the next vessel. So going back to what we did last Thursday, remember that little chart of pressures that nobody really liked? All right, that chart of pressures, I said the major theme of that is we need to understand that blood is going to flow from an area of higher to lower pressure. So once the pressure drops in the next chamber or vessel, then blood will flow from an area of higher pressure, so let's say it's flowing from the right ventricle, to the area of lower pressure in the pulmonary trunk, when the pressure in this ventricle rises above that of the pulmonary trunk. So therefore, the heart is going to have a harder time if you increase the amount of pressure in these vessels. Things that might do that, hypertension. Anybody know what hypertension is? High blood pressure. High blood pressure, obviously, like it sounds, increases the pressure in those vessels. High blood pressure increases afterload. It makes the heart have to work harder to overcome the pressure in these vessels in order for those ventricles to push it out. So over time, an increase in that afterload causes the stroke volume to decrease. I put a little picture of the heart here, and he's sweating, pushing a wheelbarrow. So it's having to work a little bit harder because of that afterload, so the pressure after it. Atherosclerosis, I'll talk about this in just a minute. This is basically a buildup of plaques that sit around in the arteries. They can increase blood pressure. They can be very dangerous. So that leads to hypertension. Something else that could increase afterload. Narrowing of, let's say, the aorta whenever it loses elasticity. So when we dissected hearts in lab last week, did you see how elasticy the aorta was? Because it has to stretch out whenever that high volume of blood pumps into it. If the aorta loses its elasticity or narrows, that also is going to increase the afterload. So it makes it harder for this ventricle to overcome the pressure in this vessel. So when we think about our balloon, here's my balloon. So if we think about our preload, our amount of blood here, so the higher amount, the greater the preload to push it out. But think about my fingers holding this opening shut. If I put more pressure here against this, it's going to make it harder for this air to come out of the balloon. If I don't have any pressure, it makes it easier for it to come out. So the afterload is the pressure in the next vessel that has to be overcome for those ventricles to pump out. And again, the key here, increases in afterload causes stroke volume to decrease. So those are our three major factors that regulate stroke volume: preload, contractility, and afterload. So we'll need to write out a question. Everybody feel okay with that? To go back to our chronotropic agents, can anybody think of something that might be a positive chronotropic agent? I said sympathetic nervous system? Things like caffeine, right? You drink a big cup of coffee. That would be considered a positive chronotrigger. All right. So, now we're going to talk a little bit about the nervous system and how it relates to the heart. So, nervous supply. This is where those terms that I talked about will come in handy. So, several factors that regulate the rate of the heart. Autonomic nervous system. So we said that the heart, without any nerves attached to it, is going to be about 100 beats per minute, because that's how many times the SA node fires. But usually in a normal person, their heart rate is lower than that. And that's because of influence from the autonomic nervous system. Other things that can affect the regulation of the heart rate, hormones. For instance, whenever your adrenal medulla might release things like stress hormones, epinephrine, norepinephrine, it can speed up the heart rate. Cations, okay, so things like calcium. Age, gender, physical fitness, and temperature, all of those things will also influence the heart rate. So what we're going to look at mostly right now is the nervous system regulation. So you don't have to draw this out because this is this picture, and you guys know that I'm not a outstanding artist, so I'm going to just try to draw the heart here. Or not the heart, I'm sorry. The brain. I'm going to draw the brain. And the normal cardiovascular center of the heart is the medulla oblongata. So the cardiovascular center of your brain, I'm sorry, that's the cardiovascular center of your heart. Cardiovascular center of your brain is the medulla oblongata. How many people remembered that from AP1? Okay, a couple people. All right. And going down here, we are going to draw the heart. So here's our heart muscle. And we're going to see how this affects it. So first of all, we're going to look at the sympathetic nervous system. So I'm going to write our sympathetic in red. First of all, I just want to make sure everybody recalls this. Sympathetic nervous system is, what effect does that have on body tissues? How do you describe the sympathetic nervous system? Is it fight or flight or rest or digest? Fight or flight. So sympathetic nervous system is fight or flight. If you don't remember that, you need to make sure you review it. So sympathetic nervous system is fight or flight. So this is more like a panic response. So coming from your cardiovascular center here, we've got cardiac accelerator nerves. I like that name because it's easy to remember. So your cardiac accelerator nerves go to the SA node, the AV node, and then basically all over the myocardium. So I'll just write myocardium here. So cardiac accelerator nerves increase the stroke volume, so they speed up the heart rate, and they also increase contractility of both the atria and the ventricles, because notice that they contact the heart muscle all over. So what they do is they increase the rate of spontaneous depolarization in the SA and AV node. They speed it up. Now these sympathetic nerve fibers going to the heart are adrenergic. So I kind of ended with this last Thursday. What do adrenergic fibers do? What do they secrete? Okay, norepinephrine, I think I heard that. Adrenergic fibers secrete norepinephrine, and they act on adrenergic receptors. In particular, the type of adrenergic receptors are called beta-1 receptors. Now, we did talk about this in AP1. I don't know if you remember that or not. But beta-1 receptors on the heart bind norepinephrine, so they increase contractility and speed up the heart rate. So two major things the sympathetic nervous system does here. Speeds the rate of spontaneous depolarization. And second, it enhances calcium entry for greater contraction. It's also a positive inotropic agent. Okay, so using my blue marker, I'm going to do parasympathetic. How do we describe our parasympathetic nervous system? Rest and digest. So just based on what you know about the parasympathetic nervous system, what do you think it's going to do to heart rate? It decreases heart rate. So the nerve that is going to be involved in parasympathetic response is the vagus nerve. Remember, that was cranial nerve number 10, the vagus nerve. It was the major nerve of your parasympathetic nervous system. And I didn't write the name of the cardiac accelerator nerve. So your cardiac accelerator nerve is going to go down to innervate the heart for sympathetic nervous system. But your vagus nerve works on less areas. It works on the SA node as well, works on the AV node, and only works on the atrial myocardium. So your vagus nerve works on the SA node, AV node, and atrial myocardium. It decreases the rate of spontaneous depolarization, so it decreases the heart rate. Now, your parasympathetic nervous system is only involved in decreasing the heart rate. It doesn't always necessarily decrease contractility. But the fibers here are cholinergic fibers. So cholinergic fibers, it's your vagus nerve, act on cholinergic receptors. Of the heart. So what do cholinergic fibers secrete? Acetylcholine. Cholinergic receptors bind acetylcholine, right? Yes.
This is probably just a question, but they will not work at the same time, right?
That is a good question. Now remember that your parasympathetic and sympathetic nervous system tend to balance one another out. So usually if one thing is subordinate to the other, your parasympathetic will be subordinate to your sympathetic. So in an emergency, that will take over. Now normally in a resting heart rate, since your SA node fires 100 times per minute, your vagus nerve is going to have some input on it during rest and digest. But they do alternate to have sympathetic and parasympathetic tone. Okay, so yes, you've got these different receptors here because the heart muscle is a little more complex. So these are going to be affected also as your body detects blood pressure, which we'll talk about in our next chapter, which is closely related. So your body constantly monitors all that for you in the cardiovascular center of in your medulla oblongata. So that way it does alternate and can act on certain areas. So that is a good question. So another question here to think about. Beta blockers. And I'll just write it out this way so everybody makes sure they understand what I'm saying here. Beta blockers. I just wrote the Greek letter beta. Well, how do you think a beta blocker? Anybody ever heard of that drug before? How do you think that would affect the heart? So what receptor is it going to work on over here that we talked about? Adrenergic beta 1 receptors. What did binding those beta 1 receptors do? What did it do to the heart rate contractility? It increased it, okay? Because adrenergic receptors, these beta 1 receptors, bind norepinephrine, which speeds up the heart rate and increases contractility. So if you have a beta blocker, you have something that is blocking norepinephrine from binding there. So what effect do you think beta blockers are going to have on the heart? Lower the heart rate contractility. When are beta blockers sometimes prescribed? Sorry? Okay, maybe to lower blood pressure, right? So high heart rate, high contractility, beta blockers may help lower blood pressure. So that may be where you hear those sometimes. So your heart beats more slowly with less force, thereby reducing the blood pressure. Now this is just kind of a summary slide, and I drew it out on the board because I think if I draw it out, that makes a little more sense. But I do want to show you, here's a figure that is probably nicer to look at than mine. I just like to draw it out. And I'll talk about this in just a minute, but I do have some slides explaining each one of those. But if your cardiovascular center of your brain is the medulla oblongata, there are several influences, like I was just answering Journey's question here, about how these know when to fire on what areas of the heart and what amount of each to put out. So they get feedback to the higher centers of the brain usually. And things that will influence the heart rate and give feedback to the medulla oblongata are these things: the limbic system and the cerebral cortex, proprioreceptors, chemoreceptors, and baroreceptors. So I'm going to name what each one of those are. Okay? So first of all, the limbic system and cerebral cortex. Anybody remember what your limbic system is? Your emotional brain. How many people remember that from AP1? All right. Limbic system is just your emotional brain. So someone can tell you something that made you feel very emotional. Do you think that would affect your heart rate? Yes. Cerebral cortex, reasoning. I've talked to several of you about this when you get a lot of test anxiety. You look at test question number 1 and you're like, oh crap, I don't know this one. And then you go to the second one, you think, I don't know this one. And then what happens is your cerebral cortex, your reasoning, starts going to the past and thinking, I always do bad on tests. I'm not going to do good on this one. And then it goes to the future and it says, I'm going to do really bad on this one, and I'm going to fail this test, and I'm going to fail every test, and you tend to go into these spirals. And then your heart rate goes up, your sympathetic nervous response takes over, and you blocked out your critical thinking. So limbic system and cerebral cortex can definitely influence your heart rate. These are emotions and higher brain centers. Proprioreceptors. You may want to jot this one down because people tend to forget this throughout AP2 all the time. I think proprioreceptors are really cool. They can monitor the position of your limb movements. So if I don't look at my arms right now, I know they're over my head. Okay? I'm not just, oh, are my arms over my head? I didn't even know. Okay. I put them there on purpose, but I can feel the position of my limbs. I know where they're at. That's because I have these proprioreceptors, nerve endings, that are located in the limbs and in those joints. I think this is really interesting because if I started doing jumping jacks right now, before my muscle tissues even needed more oxygen to supply that higher need for oxygen to my muscles, my heart rate would speed up and my breathing rate would speed up. But what they've noticed is your breathing rate increases and your heart rate increases. So your cardiac accelerator nerves act on the heart quicker. But way before you actually need that more oxygen to your skeletal muscles. And that's because the proprioreceptors send feedback to your cardiovascular center, which speeds up the heart rate. So your heart's not going to wait until it's almost out of oxygen to start speeding up the heart rate and get it to all your skeletal muscles. It happens early on because of these proprioreceptors. So they just monitor limb movements. Another thing that will influence heart rate is chemoreceptors. Chemoreceptors just monitor chemicals in the blood. to be things like hormones, drugs, caffeine, oxygen and CO2, calcium and potassium. Just gonna skip here real quick. But here's some of those chemicals. So hormones that might speed up the heart rate: epinephrine and norepinephrine released by your adrenal medulla during stress. Thyroid hormones. What does your thyroid do? Regulates metabolism. Elevated potassium decreases the heart rate, and elevated calcium speeds up contraction. So we talked about those. And of course, there are other things that will influence heart rate there. So those are all chemicals. Now the last thing on that slide are baroreceptors. And honestly, I'll come back to this when we talk about blood pressure because they have more to do with it. But blood pressure is closely related to the heart rate. Baroreceptors are little receptors located in your large arteries that detect stretch. So they detect stretch in the vessels. We'll just say that for now. This is just showing the membrane potential or action potential of a nodal cell, a pacemaker cell, and a normal heart rate of 75 beats per minute. So notice here we have depolarization to threshold, complete reversal of the membrane potential accomplished by calcium, and then repolarization, which is taking it back down to resting membrane potential. So see, there's a pattern here. This is with parasympathetic stimulation with your vagus nerve, releasing acetylcholine. What do you notice about this? Slower, right? So notice that it increases your potassium permeability here, and it's hyperpolarized, goes below your resting membrane potential. Then you have a slower rate of depolarization. So that's what your parasympathetic stimulation does. This is a picture of the same graph, so your nodal cells depolarizing, with sympathetic stimulation. So this is when your heart rate is about 120 beats per minute. What do we notice here? Your heart rate is sped up with norepinephrine. So you have reduced repolarization time and more rapid depolarization. So you can actually notice on the graph here how it relates. And usually that's going to be related directly to calcium. All right. I already talked about this, I just have some slides on there. Again, I talk about it as I draw this out. But in cardiac accelerator nerves, act on the SA node, AV node, all over the myocardium. Adrenergic receptors release norepinephrine on beta 1 receptors of the heart. It speeds up spontaneous depolarization and enhances calcium entry for greater contraction. So you see the person here exercising, which activates that, and here somebody is freaking out or something. Realize that he missed the day of the AP. Well, he's on his cell phone here, so it's like, we had an exam today, that's what I'm That's funny. And then parasympathetic stimulation, here's our little frog in Zen mode. I just thought it was cute. So cholinergic receptors are affected by acetylcholine, slows the rate of depolarization. All right. Now this is just a nice summary slide for you, summarizing lots of things we talked about. An increased stroke volume, increased preload, contractility, and decreased afterload. And then we increase the heart rate by sympathetic nervous stimulation, chemicals, and then, I don't know, if you're old or young, if you're a female, physical fitness, things like that, increased heart rate, all of those things lead to increased cardiac output. All right, so just really briefly, exercise increases cardiac output in several ways. It also increases your HDL. Anybody remember what HDL is? Your good cholesterol, right? Increases your good cholesterol, that removes the bad cholesterol. That's why it's good. Decreases blood blood levels of triglycerides, improves your lung function, so allows you to get in oxygen easier, lowers your blood pressure. I'll talk about how it does that with the blood vessel lecture. And also assists in weight control. So exercise does several things. Also makes your heart pump more efficiently, so the rate doesn't get as high, so you have increased breathing. Finally, last two slides. These are kind of interesting because most of the time people have heard of these. We're going to talk a little bit about coronary artery disease and then congestive heart failure. All right. So a little bit about coronary artery disease. When we talk about coronary artery disease, we're talking about blocking these coronary arteries, which are part of coronary circulation that supplies the myocardium with its own blood. So notice this is showing a progression. Coronary artery disease is a progression. You get fatty deposits caused by an increase of LDL circulating in the arteries. So two other terms here. You've got arteriosclerosis, which is increase in fatty plaques in arteries. Which can lead to atherosclerosis, which is the accumulation of fatty plaques in large and medium-sized arteries. And this can happen all over the body. This doesn't just always happen in coronary arteries. Since we're talking about heart here, we're talking about coronary artery disease in particular. So arteriosclerosis, an increase in fatty plaques in the arteries, which leads to atherosclerosis, where you get an accumulation of fatty plaques in arteries. So notice what happens is you get these plaques building up, and they start to block coronary arteries. Now, how this really happens, if you have a lot of bad cholesterol, a lot of LDLs, they tend to deposit within your arteries, if you remember that from AP1. HDLs are bad cholesterol, and they come through and remove those. So that's why HDL is good, LDL is bad. But as these LDLs, these bad cholesterol, build up in those arteries, they end up triggering an immune response. You end up having macrophages that try to eat up this LDL. It causes inflammation. And then you've got this buildup of plaques that sit inside the walls of the arteries. And so it also decreases the elasticity in here. So obviously in coronary artery disease, this is particularly dangerous because you get near blockages of these. Now sometimes if someone has blockages in some of these coronary arteries, they don't have any symptoms. It can be silent. They could also have angina pectoris. That just means pain, so chest pain. Sometimes it'll cause chest pain, sometimes not. Worst possible scenario here, they have a heart attack, which is known as myocardial infarction. So everybody knows that. If you don't know that, myocardial infarction. Write it up here. It's a heart attack. And remember that your coronary arteries are anastomosis, which means that you have more than one artery going to the same area. So this is why you will hear some people say they have several blockages leading to the same area. If that blockage is in a very important area going to the ventricles, that heart attack could result in death. Risk factors for coronary artery disease. First of all, this is important because it causes 7 million deaths annually in the United States, and it is the leading cause of death for both men and women. Anybody know what the number one risk factor is for developing coronary artery disease? Quite a few risk factors. Number one is smoking. That's considered to be linked to the highest incident of coronary artery disease. But other things, high blood pressure, diabetes, high cholesterol, this is interesting, a type A personality, genetics, obesity, a sedentary lifestyle, family history again, so all of those things are risk factors. Now some of those can be managed, so weight loss, relaxation techniques, cholesterol medication, diet, right? Cessation of smoking, other things like your age, your gender, sometimes personality type, family history can't be controlled, but other things can. Yeah. Type A personality, I'm assuming that the biggest thing is that it just maybe causes more stress, the level of hormones in the blood stress. So they just linked that to a higher incident. So several things they can do. Bypass grafting may be what more people have heard of. They take an artery from another area and they just make a bypass. They have a picture of this in your book, but they will bypass the blocked artery and make kind of like a new road. Another thing they will do sometimes is insert a balloon catheter. And basically they insert something kind of like a little balloon that goes up into the blocked artery, and what it does is it balloons out and it squishes the plaques up into toward the side. So those are two treatments that they have for those. Sorry? I mean, it may just depend on what's easier in the person, the type of surgery that they have. Sometimes it might be a little easier to get in the balloon catheter, but it might be, I think, more efficient because you don't have any plaques in the new artery that's made with graft. So it may just depend on the situation. And one thing I definitely want to make sure we talk a little bit about is congestive heart failure. So this is something else I will probably have you answer a question about at the end of the test. Like an essay type question. But congestive heart failure is described as any condition that reduces the heart's ability to effectively function as a pump. Congestive heart failure is any condition that reduces the heart's ability to function effectively as a pump. Now that could be many things. That could be due to long-term high blood pressure, it's due to the increased afterload. It could be myocardial ischemia, which means blockage of blood flow. I'll write that down, myocardial ischemia is a blockage of blood flow. A heart attack, myocardial infarction. It could be due to major electrolyte imbalances. It could be due to a valvular disease, where the valves are not functioning correctly. So anything that reduces the heart's ability over time to effectively function as a pump. So generally what happens is over time you get decreased stroke volume, which leads to decreased cardiac output, okay? Decrease the amount of blood ejected from the ventricles, you decrease overall cardiac output to the body. Decreased stroke volume leads to decreased cardiac output. Now there's kind of a lethal positive feedback system in congestive heart failure. Let me get my black marker because I'm thinking it shows up better. But what happens initially you get an increased preload. As heart backs up. We'll say as blood backs up. So initially you get an increased preload as blood backs up due to low heart function. So let's picture this happening. Your left ventricle, we'll say, fails first. And it is not pumping efficiently, okay? Your blood backs up in which direction if the left side of the heart fails first? What do you think? All right. If the left side of the heart backs up, you're going to have more pulmonary congestion. So left-sided failure affects pulmonary circulation. So if the ventricle isn't pumping out all the blood efficiently, your preload goes up, the amount of stretch on the heart. Now going back to what we said about preload. What usually happens as a result of a high preload, because that's usually a good thing, right? What normally happens as a result of high preload? Your heart, not enlarges, but it contracts more forcefully, right? So the higher the degree of the stretch on the heart, the more forcefully the heart muscle contracts. So initially it's going to do that. However, as this continues, the heart weakens. Because it becomes overstretched. So it becomes overstretched and the heart weakens. And that ends up being a dangerous positive feedback loop. Because what ends up happening as the heart continues to become more overstretched, the muscle weakens even more. As it weakens, the preload gets greater and greater, which weakens it even more. So that can become a lethal feedback loop. That's what happens in congestive heart failure. So it gets overstretched, overstretched, overstretched. Then it gets exhausted. The more exhausted it gets, the less blood it can pump out, which therefore stretches it more, and it gets more and more exhausted. So lethal positive feedback loop. So if your left ventricle fails first, you end up with pulmonary edema. Notice in the picture there, that man has pulmonary edema. You end up with fluid in the lungs here. Because blood is backing up in the pulmonary end. What would happen if your right ventricle fell first? Systemic circulation. Right ventricle failure backs up the systemic circulation. So you end up with what they call peripheral edema. And you might notice that people have swelling in some of their limbs. Your kidneys also tend to cause that as well, because since the cardiac output is low, your kidneys try to retain water in order to increase it, so they also compound it even more and make you retain even more fluid. So pulmonary edema is if left-sided heart failure is first, peripheral if the right ventricle. Now usually surgical treatment has to be involved. Sometimes they'll add a new pacemaker, If there's been too much damage over time, they may even consider a heart transplant. But before we get into surgical treatments, usually drugs try to accomplish several things. First of all, drugs try to rid the body of fluid from the kidneys. So they try to make you pee, in essence. So they cause the kidneys to get rid of water. Second things that drugs do, increase contractility. Think about positive inotropic agents. Positive inotropic agents increase what ion usually? Calcium. And then the last thing that they try to accomplish is decreasing afterload. So if that's high blood pressure, they attempt to decrease the high blood pressure. So the first thing they would do in early congestive heart failure, give you drugs that would promote fluid loss, decrease afterload, and increase contractility. It gets very serious, you get a pacemaker, and then if the heart is just completely worn out, transplants. So mostly everything we talked about today are those three things that influence stroke volume and the nervous system stimulation of the heart. So for your exam, I'll probably come up with a little less than 50 multiple choice questions. Something around like 45 maybe. And I'm going to ask you to explain those three things that affect stroke volume. So preload, afterload, contractility. Yeah.
Are we gonna have to trace a drop of blood?
Yes, you will need to know how to trace a drop of blood through the heart. Now hopefully that is really easy to do because you're also going to have to do that in lab. That's just anatomy. Trace a drop of blood through the areas of the heart. The whole thing, yes. So if you start with one area, end up in that area. Just like we did in lab. And then finally, I want you to tell me some things about congestive heart failure. It's important to understand congestive heart failure.
These are all the same questions.
Okay, what questions do you have for me? No questions? Yes. Okay, so for calcium, sodium, and potassium. Sodium and calcium will go in when the channels are open, potassium goes out. So that's why either sodium or calcium are always involved in depolarization, and potassium in repolarization. Yeah.
We're talking about tracing the drop of blood from the heart. Are we going to have to include the heart's own blood supply as well? Or just
No, yeah, the question was, do you have to include the heart's own blood supply? That's not really part of systemic and pulmonary, so I'm just referring to systemic and pulmonary. Okay. Yes.
So the graph that like goes up and then it plateaus and then it goes down.
Yes.
So when it plateaus, it's a calcium and potassium exchange, right?
Yes, so she's talking about the action potential graph of a contractile cell. They have a plateau phase that allows those gap junctions to take the stimulus to all the contractile cells. So it hovers around 0 millivolts because as calcium comes in, potassium goes out. So the positive ions balance each other. Yes. You do need to know oxygen-rich, oxygen-poor. Now, either way, you do have a lab test over that same thing after this, so it would be helpful there. But if you can trace a drop of blood through the heart, it should hopefully be easier to see which ones are oxygen-rich, oxygen-poor, because you should know that where the oxygen-poor blood comes in at the right atrium, and it has to go to the lungs, and then where it picks up oxygen and goes through. So that kind of contributes to the overall understanding. Yeah. Yes.
as far as how we actually write down the answer to that question, if we do it
Sure. Now, if you ever want to draw pictures, I have some people that just think in a more artistic brain and they like to draw a picture every time. That's fine. What I like to avoid is people writing out answers and just memorizing a picture, but then they have no idea what goes on with it. So what I've tried to do is ask, multifaceted questions, little parts with some of them. I may not always be able to do that, kind of like with knowing the circulation through the heart is just memorization. But for instance, on the muscle exam, I tried to ask questions, not just memorize a chart that says slow oxidative, fast glycolytic, fast oxidative glycolytic, but say if somebody were doing this type of exercise, what type of fibers would they use? And people that understood it were able to apply that information they knew. And then people that just memorized a chart, and put it on the exam. They didn't answer the question because they didn't know how to utilize those. So that's what I'm trying to avoid this semester. I think it helps for me to tell you some of those essay questions because it makes people maybe a little less stressed out and you can study those major concepts. But then I sometimes get into the problem that people want to draw a picture or write out an answer and memorize everything, but they don't understand any of it. As long as you draw something out and I can see how you drew it, and I can tell you understand it, that's fine. Any other questions for me? All right, I'm not gonna start the blood pressure today. Exam will be Thursday, case study isn't due until the next Tuesday. I already have the stuff for blood pressure and blood posted, so you don't need to worry about those for this next exam. I just want to make sure.
So the case study is not due on Thursday?
No, the case study will be due the next Tuesday. That gives you a little bit more time. So I put the due date online as Thursday, but you said last class period I was pushing it. All right, I will see you guys on Thursday. Please feel free to email me or come by my office or the Learning Center with any questions that you have at all. Yes.
Everything on your right to your lungs, everything on your lungs left goes to your left, right? The blood from the lungs leaves, so it left the lungs and goes to your left and right.
Yes.
I kind of remember little things like that.
Yeah, it goes to the left side of the heart from the lungs, and then that pumps, the left side of the heart pumps it out to your urine.
Okay. You need to go down to apex, and apex is the thickest because it's the most
If you're having coronary arteries,
That's why I miss my shoes.
usually they don't pull out that whole artery, they just do a bypass, they do it around. So that's what a bypass is, they put like, yeah, and I need to find the picture, I don't know if I had access to it, that's why I didn't put it in here. But the book has a good drawing where they've done a bypass where you can see like if this were the heart, it was like the marginal artery over here.
Right.
Like the marginal artery were right there, they would have a little graft that went like this. So it could bypass.
That just goes
that.
around it?
Just went around it, right?
All right, thank you.
Uh-huh. If you have a rubber band you don't want, sure, go ahead and give it back to me and I'll use it later. You can keep the balloons.
Yeah, with our mouths on, remember? We'll be sharing it if you share it now.
That's okay. No, if you know those and you want to include them, they're fine, as long as I can put a trace or drop of blood. It should be, I know this
I
is
see
what
you
you're
were doing
learning,
right
so it's
there.
not easy, but it should be because it's just anatomy and utilization, a fairly easy way to gain points on this.
I was thinking if you wanted like those specific things.
It's good the way we did it. Yeah. In the learning center? Yes, I'll be in the learning center today from 2 to 3 and tomorrow. And I'll be in my office, of course, the hours in between that, so you're welcome to come by my office too. So that's fine. Sure, sure.